Thank you, Corey. Good afternoon. I want to thank Corey and Jim and others for inviting me to talk to you. My focus is going to be on adenocarcinoma, which is almost 50 to 60% of all non-small cell lung cancers we see in the US these days. As you all are aware of, the incidence of adenos have increased gradually over the past 3 or 4 decades, while squams have come down. In Europe, the trend is lagging by about 20, 30 years from that of US, but even there, they're seeing less and less squamous. This slide shows my disclosures. As I constructed my talk, I realized that there are 2 lectures coming right after this, one focusing on EGFR and the other one on driver mutations besides EGFR. So you're not going to see a lot of EGFR or ALK in my talk, and that's because we wanted to avoid overlap to the extent possible. So I'll talk about systemic chemotherapy. For majority of patients with adenocarcinoma, chemotherapy continues to be the most effective treatment option. Targeted agents are increasingly being tested and used. We'll discuss that. And salvage therapy is a setting where we're seeing more and more targeted agents enter the space, and we'll go over some of the recent data with these agents. So this is sort of the treatment algorithm I use for my patients at Emory. In any patient diagnosed with non-squamous non-small cell lung cancer, in majority of the instances, you know clearly it's adenocarcinoma based on either TTF1 positivity by immunostain or NAPSIN-A, which is another stain pathologists are using more and more commonly now. So if either one of these are positive, you know it's adenocarcinoma histology. Sometimes you have poorly differentiated carcinoma without a histological subtype identified by the pathologist, and for those patients could also be potentially included in this. And molecular testing is now considered standard for all patients with non-squamous non-small cell lung cancer. You may also want to consider testing your never smoker squams that are very rare, but occasionally you see them. And when you see them, chances are that's a mixed adeno and squam, and it's just the fact that the biopsy was representative of a squamous predominant portion of the tumor. So you do molecular testing. What test do you do? Definitely EGFR and ALK. If you want to add ROS, I think that's very reasonable. Our FISH lab does ROS, RET, and ALK together. And EGFR is done as part of next-gen sequencing. A lot of institutions and companies are offering next-gen sequencing approaches. So you may choose to do whichever way you want to do this. But if you have a targetable mutation or translocation like EGFR, ALK, or ROS, then regardless of the line, preferably give it in first-line therapy. But if you already started the patient on chemotherapy because you didn't have enough time to wait because of a rapidly declining clinical situation, then you could consider bringing these drugs in either the maintenance or salvage therapy setting. Now, there are certain targets you might find like KRAS, HER2, RAF, PIK3CA, where these may be driver mutations, but we don't have a proven treatment or FDA-approved treatment option for these patients. And for them, chemotherapy still is reasonable. This is a common question I get asked. Somebody tests a patient, has HER2 mutation, and should that patient get a HER2-targeted therapy? My suggestion is, in the first-line setting, still go with chemotherapy, and you may want to bring the HER2-targeted agents a little lower down the batting order because they may not be as effective as an EGFR TKI is for a patient with an EGFR mutation. So for these patients, either a clinical trial or chemotherapy. And for patients whose tumors does not have an activating mutation, then you go forward with platinum-based chemotherapy. Just 2 slides on EGFR. There is overwhelming evidence now, as shown by some of the studies listed here, that EGFR TKI is superior to chemotherapy for frontline treatment. We look at specifically exon 19 and 21 mutations. There are certain other rare mutations you might see, and for those patients, it's not clear whether EGFR TKI should be the first-line therapy, even though you would still want to give them EGFR TKI at some point. 2 points to make on the slide. If you do see EGFR 20 insertion mutation in exon 20, insertion exon 20, those patients do not benefit from TKIs, so those patients should not be treated with a TKI. The second thing is, on the top you see Afatinib, which is not available in the US market, but has clearly been shown in Asia and Europe to be effective in first-line treatment for mutated patients. I say this because it's likely that Afatinib may become available in the US market sometime this year, and it's used at a dose of 250 milligrams, and it tends to have lesser diarrhea and skin rash relative to Tarceva at 150 milligrams, or Erlotinib at 150 milligrams. Afatinib versus chemotherapy, I know Ronnie and Anne might cover this, but this is a paper that was published in Lancet Oncology just a few weeks ago, where they did a combined analysis of data from 2 different phase 3 trials that compared Afatinib, an irreversible EGFR inhibitor. It has preclinically more effectiveness and activity even in Erlotinib-resistant cell lines. Clinically, whether it's more effective than Afatinib and Erlotinib is not known at this time. This was an effort to show that in exon 19 mutation positive patients, there was actually an overall survival benefit for Afatinib. In exon 21, they didn't see that big a difference. But this was making the claim that in patients with EGFR mutated tumor, especially exon 19, Afatinib shows a survival benefit which is not seen with other first-generation TKI, so perhaps this might be a preferred drug for those patients. My view is not so fast. There are randomized trials that are now ongoing and have completed, comparing the first-generation reversible versus the second-generation irreversible EGFR inhibitors, and those results should inform us what's the best way to treat. Right now, I view all of these agents as comparable in terms of how they work and how effective they are. Important to remember, Afatinib does have more skin GI toxicities compared to the first-generation drugs. Now, the chemotherapy, evolution of chemotherapy in non-squamous non-small cell lung cancer, Corey nicely showed us the data with the Giorgio trial, CISPEM versus CISGEM. I'm going to come in, look at this trial from a non-squamous standpoint. He talked about how squamous patients should not be treated with Pemetrexed. Here you see the survival curve in the non-squamous histology. Hazard ratio is 0.81, favoring CISPEM versus CISGEM. So this trial established that for non-squamous histology, CISPEM was superior to cisgemcitabine. The question then was, how does it compare to taxanes? Is Pemetrexed a better drug than taxane for a non-squamous patient population? We at least have 2 trials now where we have the data from. Many of you may not have seen this trial. This was reported at ESMO meeting last year. It was conducted in Asia, where they compared cis-docetaxel to CISPEM in the frontline setting for patients with non-squamous histology. So ECOG performance status of 0 to 2. This is a relatively small study of 156 patients. They were trying to show that the docetaxel arm was non-inferior to CISPEM in terms of the progression-free survival. And following therapy, these patients were allowed to go and crossover and get Pemetrexed or docetaxel. And what you see are the PFS and overall survival results in this trial. No big difference. The cis-docetaxel versus CISPEM, comparable numbers. Don't be swayed by the overall survival. The hazard ratio was close to 1. The medians look a little deceiving. If you look at PFS, again, 4.6 months and 4.7 months, hazard ratio is 1.01, suggesting that they both had similar efficacy in the non-squamous patient population. The response rates were also identical in the low 30% percent points. In terms of toxicity, as one would expect, the cis-docetaxel arm had more neutropenia, more serious adverse events, and fever with neutropenia. So this is where the biggest difference was seen between CISPEM and cis-docetaxel. So the investigators concluded that in non-squamous histology, cis-docetaxel had similar results as cis-Pemetrexed. These results also go along with what had been observed in the PARAMOUNT trial. Dr. Govindan is here. He was one of the leaders of that trial, where patients with non-squamous received carboplatin PEM with bevacizumab versus carboplatin paclitaxel bevacizumab. And in that trial, even though the maintenance strategies were slightly different between the 2 arms, there was no difference in overall survival. It was designed as a superiority trial to show that Pemetrexed group would do better, and it failed to meet the survival endpoint. In fact, the numbers were fairly identical for the 2 arms, and the curves were superimposable for PFS and overall survival. So taken together, it's fair to say that while Pemetrexed is a better tolerated cytotoxic agent in the frontline setting, we cannot make the claim that it's better than taxanes for non-squamous. It's definitely better than gemcitabine. Nab-Paclitaxel is also available for us in the frontline setting. This was the trial that Corey once again showed earlier, comparing carboplatin paclitaxel to carboplatin nanopaclitaxel given on a weekly basis, days 1, 8, and 15. There is no break here. It's repeated every 3 weeks. And in this trial, the response rates for non-squamous patients were very similar between the two groups. So there's no specific advantage to giving this in non-squamous patients. If you look at the overall PFS and survival results, once again, focusing on non-squamous histology, PFS was very similar. Hazard ratio was 0.93. Overall survival was 0.95 hazard ratio. So comparable in terms of efficacy to carboplatin paclitaxel, but there are certainly differences in toxicity that may push one to choose the weekly regimen over the other. And as Corey also mentioned earlier, in elderly patients, the weekly regimen is a better tolerated drug and may be associated with better efficacy. So that's where we stand with chemotherapy in non-squamous non-small cell lung cancer. How about bevacizumab and other targeted agents? This is 4599 trial. This is old news now, almost 9 years ago since it's been published. The addition of bevacizumab to carboplatin and paclitaxel resulted in improved overall survival, improved response rate, improved progression-free survival, and led to the approval of bevacizumab for non-squamous histology. The trial originally excluded patients with brain metastases, but now we have good data to show that in patients with treated brain metastases, it's safe to administer bevacizumab. In a patient who is on anticoagulation for thromboembolic conditions, it's also safe to continue or initiate bevacizumab as long as they are stable and has not experienced a recent bleed in the immediate preceding period before they are treated. In both of these, both the E4599 and the AVAIL trial, bevacizumab was continued as maintenance therapy. So the paradigm when bevacizumab was used was that you give combination of chemo plus bev for the first 4 to 6 cycles, and then if the patient is benefiting, you continue beyond that with maintenance therapy with bevacizumab. And that's how these trials were done, and that's how the drug is approved by the FDA. But the question about how many cycles of chemotherapy is optimal for non-small cell lung cancer was addressed several years ago, and we learned that 4 to 6 cycles of therapy are optimal. Beyond 6 cycles, continuing more chemotherapy results in excessive toxicity without significant improvement in efficacy parameters. So then the question came, instead of using combinations for indefinite lengths of time, can we use a less toxic single agent regimen as maintenance strategy? In other words, instead of using this paradigm where you give 4 to 6 cycles of chemo, and then even if the patient responded, you wait and watch, and then start them on chemotherapy when they progress our targeted therapy, can we give them a single agent maintenance therapy that could be effective for these patients? So that was the subject of investigation of JMN trial. Patients that received 4 cycles of platinum-based regimen randomized to Pemetrexed or placebo. This trial preceded the observation that Pemetrexed was not effective in squamous histology. Therefore, this also included squamous patients. When you look at the effectiveness of Pemetrexed in the maintenance setting, PFS and overall survival were improved. The hazard ratio was approximately 0.75 to 0.8 for overall survival, 0.6 for PFS, and showed a good tolerability in the maintenance setting, and therefore led to the approval of Pemetrexed for switch maintenance. In this study, patients did not receive Pemetrexed as part of their first-line regimen, which was a platinum-based doublet. What happens if you already used Pemetrexed in the frontline setting? Can you still continue it as maintenance? That was the question of the PARAMOUNT trial. Patients got cis-PEM, and then those who benefited were randomized to PEM maintenance versus placebo. This trial also showed significant improvement in PFS and overall survival, favoring the use of Pemetrexed as maintenance therapy. And when they looked at outcomes based on a number of baseline parameters, there was no specific difference, particularly whether the patient had an objective response or stable disease to frontline regimen. Some of the studies with Erlotinib have shown that if a patient had stable disease in the frontline setting to chemo, then they did better with Erlotinib. If they had a response to chemo, then there was no sign that Erlotinib helped those patients. But here, if you focus on this part of the curve, both patients who experienced CR, PR, and stable disease, there was a significant benefit. Hazard ratio was slightly different, but the confidence intervals were overlapping. So Pemetrexed can be used either as switch maintenance or continuation maintenance for these patients. The other drug that's approved in maintenance setting is Erlotinib, 4 cycles of platinum-based doublet followed by Erlotinib or placebo. This trial did not select patients based on EGFR mutation status, and there were nearly 1,000 patients enrolled here. What you see here are PFS data. There was a modest improvement in PFS for patients who received Erlotinib relative to placebo. But if you look at the outcomes based on mutation status, this is the curve for patients who had an EGFR mutation. The hazard ratio was 0.1, suggesting that Erlotinib maintenance helped these patients. In wild-type patients, the hazard ratio was close to 0.8, suggesting that the benefit was relatively modest. So this does not, even though the survival advantage was seen for Erlotinib maintenance in the overall patient population, and even in the wild-type population, the benefits are relatively modest. AVAPERL study brought in the concept of bringing Pemetrexed into the maintenance setting along with Bevacizumab. So in this trial, patients received frontline chemo combination of cis, Pem, and Bevacizumab. And then after 4 cycles, they got either Bevacizumab as maintenance or both Pemetrexed and Bevacizumab as maintenance. The trial was designed to look for progression-free survival as the primary endpoint with about 370 patients. This slide shows you the PFS data for double maintenance Pem-Bev versus Bev. If you look at the data from the time the patients were randomized after the 4th cycle, there was a clear advantage to 2-drug maintenance compared to monotherapy, and the differences were 7.4 versus 3.7 months. So a sound difference favoring 2 drugs in terms of PFS. But if you look at overall survival, the lower curve shows from the time of randomization, the hazard ratio was 0.87 and the p-value was 0.29. Now, the study was not powered to look for survival differences. It was a relatively small study, but shows you a hint of evidence that the combination may be better. But even there, the hazard ratio was only 0.87. So if there is a benefit, it may not be as big a benefit that we would like to see to use routinely double maintenance. However, the definitive trial that will answer this question is almost done. This is ECOG 5508, where patients are treated with carboplatin, paclitaxel, and Bev for 4 cycles. And after 4 cycles, those who have stable disease or a response are randomized to Bev, which is how 4599 was done, or taken to switch maintenance strategy with Pemetrexed, or given both drugs for maintenance. And the primary endpoint for this trial is overall survival, and we have almost 1,420 out of the 1,495 patients we need. So this should be done in the next 6 to 8 weeks, and we hope to have the results next year. This will be the first trial to compare these various maintenance strategies in non-squamous histology. Now let me talk about salvage therapy for patients who progress on first-line and maintenance treatment. Until now, we had in paper, at least 3 different options, FDA approved: docetaxel, Erlotinib, and Pemetrexed. But as many of you are already doing in your practices, Pemetrexed has moved to either the frontline and or the maintenance settings. And therefore, that leaves us with docetaxel and Erlotinib. So which drug would you use in the salvage therapy setting? I want to highlight this meta-analysis that was published in JAMA. This looked at a number of trials that have been conducted in the past 2 to 5 years that compared a TKI to chemotherapy in the wild-type EGFR patient population, in the salvage therapy setting mostly. And there are a number of these trials, and these are all modest-sized clinical trials. And just about in majority of them, the outcomes with chemotherapy were better than TKI in the second-line setting. So if you have a patient with wild-type EGFR, the notion now is that chemotherapy is a better option than giving Erlotinib. Even though in the BR21 trial, Erlotinib was better than placebo, it is approved in the second and third line setting. It is on label to give the drug in the second line setting. But in light of these evidence, perhaps using chemotherapy makes more sense in the second line setting. Now, if you're going to use chemotherapy, we know that docetaxel is the approved drug, and that has been the case for almost 16 years since it was approved in the late 90s. But now we, for the first time, have a combination approved in the salvage therapy setting. This is the REVEL trial, docetaxel plus placebo versus docetaxel plus ramucirumab. Ramucirumab, as you are aware of, is a monoclonal antibody against the VEGF-R2 receptor. And this trial showed that the combination of ramucirumab and docetaxel was associated with an improved PFS of 4.5 months compared to 3 months at the median for the control arm, with a hazard ratio of respectable 0.76. And the p-value here was quite significant. But if you look at the impact on overall survival, while it was still statistically significantly positive, the hazard ratio is about 0.85, 0.86. So a modest difference favoring the use of combination compared to chemotherapy alone. 15% of the patients enrolled to this trial had already received bevacizumab. So it's not known whether that specific group benefited from the combination, but as an overall group, there was a benefit for patients who received both drugs. So that'll be an important question to look at. And I think Corey led one of the trials that has completed accrual that looks at the role of bevacizumab in the second line and beyond settings after they've received in the first line. This is called the AVAPERL trial. And that trial has completed accrual, and we'll hopefully have an answer in the next year or so. A slide on the adverse events associated with ramucirumab and docetaxel. You see higher incidence of febrile neutropenia, 16% versus 10% with chemotherapy alone. Platelet toxicity is also higher, so keep that in mind. Some other toxicities that you don't see with docetaxel, but you do see when you give the combination of docetaxel and ramucirumab are seen here: stomatitis and mucosal inflammation. Peripheral edema is also something you want to keep your eyes open for patients who are being treated with ramucirumab. So overall, this is an FDA-approved option worthy of consideration for patients in the second-line setting. Another drug that is also targeting the angiogenesis axis, this drug got approved in Europe recently, about 4 months ago. It's called nintedanib. This is an oral tyrosine kinase inhibitor. This is actually approved in the United States by the FDA for patients with interstitial pulmonary fibrosis, and that was a very recent approval, but at a different or lower doses than what you will see in the cancer trials. But this is a multi-kinase inhibitor that targets VEGF receptor, FGFR, and PDGFR alpha and beta. We know that FGFR and PDGFR alpha are valid targets for patients with cancer. They're not driver events in adenocarcinoma in majority of the patients, but we think that they play some role in promoting cancer metastases and progression. So nintedanib is administered orally. This was the LUME-Lung trial. The slide unfortunately didn't project well, but these were second-line therapy patients that received docetaxel plus placebo versus docetaxel plus nintedanib. This was given at 200 milligrams BID, days 2 to 21 of every cycle. The overall trial showed slight trends towards improvement in outcome. When they looked at histology, if you look at patients with adenocarcinoma, that's where they saw the best outcomes for the combination, 12.6 versus 10.3, hazard ratio of 0.83, and a p-value that was significant. So even though the overall trial failed to show survival improvement, for adeno subset, there was an improvement in survival. And because it was a very large 1,200 patient trial, they were able to show significance even in a subset analysis. But it's my understanding that they are doing specific trials in adenocarcinoma patients moving forward, and we should hear about them in the months to years to come. Lastly, the one study I want to mention is Galaxy. This is looking at HSP90 inhibition in advanced stage non-small cell lung cancer. What you see here is a randomized phase 2 trial comparing docetaxel to docetaxel plus ganatisib. This is a second-generation heat shock protein 90 inhibitor, which does not have any ocular toxicity and hepatotoxicity as was seen in the first-generation compounds. We did a trial with approximately 250 patients. This was an exploratory trial with a variety of patient populations of interest. What we saw in the trial was for patients who had experienced some sort of benefit with first-line chemo, there was a modest improvement in PFS and overall survival for the combination of docetaxel and ganatisib. This is a very busy slide. We were also interested in patients with mutated KRAS and elevated LDH, which is a surrogate for tumor hypoxia, that is relevant for HIF-1 alpha at target of HSP90, but we didn't see a big difference in outcomes for those two groups, but the overall adeno patient population that were chemosensitive in the first-line setting, we saw suggestion of benefit. So there's a phase 3 trial that's being conducted for just that patient population. And this is the curve for those chemosensitive patients, which we defined as at least 6 months for the patients to be diagnosed with lung cancer, having had first line and entering the second line trial. So if they came to salvage therapy within 6 months, we hypothesized that that was more aggressive phenotype and perhaps not benefiting from first line chemo. If it's more than 6 months, that means they had some sort of benefit. So in conclusion, I think it's fair to say that individualized therapy is a reality for at least a subset of patients with lung adenocarcinoma. Molecular testing is recommended for all patients with non-squamous histology, definitely looking for EGFR, ALK, and potentially ROS1. Regardless of the advances we made in targeted therapy in recent years, systemic chemo continues to be the mainstay of treatment for majority of lung adenocarcinoma patients. Thank you very much for your attention.